Good morning, everyone. And thank you to the organizing committee for the opportunity to speak here today. As she mentioned, my name is Sharon Thompson, and I'm a second-year PhD student at the University of Illinois. And today I'll be discussing some recent work that we've conducted, which was a systematic review and meta-analysis of the impacts of soluble fiber supplementation on outcomes related to body composition, glycemia, and insulinemia among individuals with overweight or obesity. And as we've mentioned many times during this symposium, we know that the 2015 Dietary Guidelines for Americans and the Institute of Medicine recommendation is that nearly all individuals consume 14 grams of dietary fiber per 1,000 kilocalories, which equates to 25 grams of dietary fiber for most women and 38 grams of dietary fiber for most men. However, we're also aware that most individuals in the US do not meet this recommendation, and that average intake is between 15 and 16 grams per day. And this is concerning because we know that dietary fiber is protective against overweight and obesity and chronic conditions such as type 2 diabetes and cardiovascular disease. And recently, the Food and Drug Administration has set a dietary fiber definition and proposed an increase in the daily reference value on the nutrition facts label from 25 to 28 grams per day to be more in line with that DGA recommendation. And they consider fibers to be those that are intrinsic and intact in plants, and those that are isolated or synthetic, provided they have a physiological effect that is beneficial to human health. And those beneficial physiological effects include improved laxation and bowel function, increased satiety and reduced energy intake, reduced blood pressure, glucose and cholesterol, and increased mineral absorption in the gastrointestinal lumen. Pertinent to our systematic review and meta-analysis, one report showed a modest reduction of nearly 2 kilograms over a 4-month period when total dietary fiber was increased by 14 grams per day. An additional report showed that reductions in energy intake and appetite ratings that were more pronounced for soluble fiber as compared to insoluble fiber treatments. And a third report focused on prebiotic fibers, or those that are soluble, fermentable, and non-viscous, reported reduced postprandial glucose and insulin following consumption. However, they did observe mixed results for body weight and insulin sensitivity. So in this case, we consider soluble fibers to be those that are soluble in water, and they may or may not have different physiochemical properties, such as the ability to form a viscous gel in the gastrointestinal lumen or be fermented by gastrointestinal microbes. And we know that soluble fiber impacts metabolism by slowing gastric emptying, increasing satiety and bile acid excretion, and reducing postprandial glucose and insulin. And we believe that supplementation may improve fiber intakes and health among individuals with overweight or obesity. However, at this time, there's really a knowledge gap regarding the impact of soluble fiber supplementation on body composition measures and other measures related to glucose and insulin in this population. So accordingly, we sought to conduct a systematic review and meta-analysis focused on randomized controlled trials of soluble fiber supplementation among otherwise healthy individuals with overweight or obesity. And we hypothesized that soluble fiber supplementation would improve these measures of body composition, glucose, and insulin in this population. And so we conducted a systematic review and meta-analysis of randomized controlled trials. This is our clinicaltrials.gov identifier. And we conducted the systematic review and meta-analysis according to the Cochrane Handbook and reported it according to PRISMA guidelines. We included the following databases in our search: PubMed, Web of Science, CINAHL, and Cochrane Library, and utilized the following eligibility criteria. So studies were eligible to be included in our systematic review and meta-analysis, provided that they included solely individuals with overweight or obesity, but without previously diagnosed chronic disease. We also excluded studies if they did not have a placebo comparison or provided supplemental fiber treatment alongside dietary counseling or energy restriction. And we included the following variables in our data extraction process. And so I'm just going to, I had a pointer, but so I'll just use this here. But yeah, so We extracted information related 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 information percent indicated considerable study heterogeneity. So as you can see, both from the forest plot and our I-squared value, the study heterogeneity for body mass index in particular was considerable. And as I mentioned, we conducted a sensitivity analysis to identify potential influential studies with regard to study significance and heterogeneity. And so what I will show after some of these forest plots and analyses with high I-squared values are the subsequent plots with the most influential study removed. And so in this case, the study by Genta et al. Was removed, and as you can see, a majority of these mean differences remain on the left-hand side of the y-axis, and that there was a significant reduction in body mass index when soluble fiber treatments were compared to placebo. And also the I-squared value was reduced. We also analyzed body weight in these studies, and we observed a significant reduction of 2.52 kilograms when soluble fiber treatments were compared to placebo. Again, we observed considerable study heterogeneity. And thus, in this subsequent slide, I have removed the most influential study with regard to heterogeneity, which was, again, Genta et al. And as you can see, our results remain significant, and that there was a reduction, when this study was removed, of 1 kilogram of body weight when soluble fiber was compared to placebo. 4 studies were included in our meta-analysis of body fat percentage. And we observed a significant reduction in body fat percentage when soluble fiber treatment was compared to placebo. And again, we can observe a high I-squared value indicating considerable study heterogeneity. In this case, the most influential study was one conducted by Parnell et al. And upon removal, the results remained significant and the I-squared value was reduced. A meta-analysis conducted focused on fasting glucose observed a significant reduction in this outcome when soluble fiber was compared to placebo. In this case, the I-squared value was in the moderate range, and so thus I have not included a subsequent slide with an influential study removed. Fasting insulin was also significantly reduced when soluble fiber treatments were compared to placebo. And in this case, the I-squared value was 88%. And again, this study by Genta et al. Was the most influential with regard to study heterogeneity. And interestingly, when this study was removed, one can see that the I-squared value has dropped from 88% to 0, indicating perfect overlap with regard to these studies, and that the results remain significant. When we assessed publication bias using Beggs and Egger's test, we observed that these tests were non-significant for all outcomes, indicating a potential absence of small study effects or publication bias. Our meta-regressions revealed that insulin resistance was more substantially impacted by non-viscous fermentable fiber supplementation as compared to viscous. But our meta-regressions focused on length of intervention and fiber dose were not significant for any outcome. So in conclusion, our results showed that soluble fiber supplementation was connected with reductions in body mass index, body weight, body fat percentage, fasting glucose, and fasting insulin among individuals with overweight or obesity, independent of researcher-imposed energy restriction. And there are a number of strengths to this study. So we utilized high-quality studies in our analysis, and a majority of these studies, all but one, were double-blinded randomized controlled trials. And we also assessed a variety of soluble, viscous, and fermentable fibers. However, some of our limitations weren't paused. So there's a high study heterogeneity, which one can observe in other meta-analyses on these outcomes. And we attempted to address this heterogeneity using sensitivity analysis. Also, we have a limited ability to generalize our results to all overweight and obese individuals, those within a healthy weight range, and individuals with chronic conditions. However, we believe that our findings really add to the weight of the literature regarding the health benefits of fiber consumption. particularly among individuals who are overweight or obese, who have been found to have lower intakes of dietary fiber. However, at this time, really, future robustly designed randomized controlled trials are needed to evaluate additional dietary fibers, including the 26 that were recently reviewed by the FDA. And we may consider adding additional health benefits to the FDA list, including those that we've analyzed and presented here today. So I would like to thank our funding sources. So the College of ACEs Jonathan Baldwin Turner Fellowship, funding by the USDA. Our research collaborators, Dr. George Fahey and Caitlin Edwards. And I'd like to thank Dr. McCarron from Tufts for her very helpful dietary fiber database, which we utilized for our backwards search. And with that, I'll take any questions.
Thank you. Very nice work with the meta-analysis. And I'm curious about the study duration, because when it went by quickly at the front, it looked like it was 1 week or longer. So I'm assuming the fasting glucose insulin tends to come from shorter studies, but the body weight. I'm just curious, when did you have short durations, when did you have long durations?
I can show you that.
Studies?
Yes, so this is a supplemental table that indicates that information for all eligible studies. And as you can see here on the right, these are the outcome measures that were evaluated. And so in many cases, even if the study authors did not report the results of these outcomes of interest, in our case, we analyzed them. So it wasn't necessarily, in my view, a case where they assessed one or the other, but frequently they would provide all of those variables which we analyzed.
But do you tend to have shorter duration studies on the insulin glucose?
Yeah, so as you can see here, the study duration ranged from 2 to 17 weeks. And so, but the primary outcomes were, a majority of them were related to appetite, energy intake. There were a few that were related to body composition or metabolic syndrome risk factors. But in many cases, yeah, glucose, insulin, body composition were not necessarily like the primary outcome for those authors. Thank you.
I had the good fortune of sharing dinner with Sharon last night. Nutrition, dietary fiber research is in good hands.
Thank you.
The question deals with what should be a requirement for fiber. Among your studies, I assume all the subjects had a normal dietary fiber intake of about, say, 18 grams a day. Is that about right?
Unfortunately, only one study assessed baseline fiber intake. And so that is the limitation. We are unsure whether or not, yeah.
Okay, I think the 18 is low, and I could talk about that. That's a, and the values of 25 and 38, I think are for the wrong reason. But based on what you saw, and in your opinion, what should we increase dietary, if we had an 18 grams of average, and you looked at different fibers for different benefits, what would you recommend maybe an intake of dietary fiber for a population?
Are you referring from supplemental sources or from Whole Foods?
Okay, total. I'm not, if you want, you could separate it into supplements or just total dietary, just your intake, your intuition based on all the data, and maybe you formed an opinion.
Oh, sure. I mean, well, studies by Dr. O'Keefe have, evaluated, dietary fiber intakes, 50 grams per day. But, I mean, the fact is a majority of people do not even reach 20.
Based on the data you looked at, can you give an opinion, what you think, your opinion, what maybe a good fiber intake is?
Well, I mean, I would go with the dietary guidelines for now. I mean, I think we could definitely do better than that. But at this time, it's really trying to be realistic with regard to actual intakes and trying to get people to increase.
Thank you.
All right, we have time for one more question.
Yes, I thank you for the very meaningful work. And then my question is about the multiple variables you see very high heterogeneity.
Yes.
The I-square value is pretty high. How that can use or influence your study interpretation?
Absolutely. So the Cochrane Handbook, which we utilized for this study, they provide different options when study heterogeneity is high, and one of those is to investigate the sources of study heterogeneity. So that is what we've done with the sensitivity analysis. But with regard to the effect on our outcomes, really, it's variability that is within the treatment. So no treatment was provided twice. So they're all soluble fiber treatments, but no treatment has been provided twice. So that is inherent variability. And there is also inherent variability within these outcomes because they were assessed in different ways. And so really it's unknown exactly how this could influence our study. I mean, because there are so many factors involved that that may be influential, but we've done our best to try to address it or assess it using sensitivity analysis, but thank you.
Great, thank you.